Bonsoir et bien.
Good evening and welcome to this meeting of the Special Joint Committee on Medical Assistance in Dying. I would like to begin by welcoming members of the committee and witnesses, as well as those watching this meeting on the web.
House of Commons Joint Chair of the committee. I am joined by the Honourable Yona Martin, the Senate's Joint Chair of this committee. Aujourd'hui, nous entreprenons notre examen du...
Today we begin our examination of the degree of preparedness attained for a safe and adequate application of medical assistance in dying where mental disorder is the sole underlying medical condition in accordance with Recommendation 13 of the committee's second report.
I remind members and witnesses to keep their microphone muted unless recognized by name by the Joint Chair. A reminder that all comments should be addressed through the Joint Chairs. And when speaking, please speak slowly, clearly, and as near as you can from the microphone for the interprets. Interpretation is this video in this video conference will work like in an in-person committee meeting. You have the choice at the bottom of your screen of either floor, English, or French. Enfin, j'aimerais souhaiter...
I would like to virtually welcome our first two witnesses. From the Canadian Psychiatric Association, Dr. Alison Freeland, Chair of the Board of Directors and Co-Chair of the AMAD Working Group.
Association represented by Mrs. Shelley Birnbaum, Chair of the End of Life Working Group. Thank you for joining us, Madame Freeland and Birnbaum. We'll begin with opening remarks by Dr. Freeland, followed by Mrs. Birnbaum. Dr. Freeland, you have 5 minutes. The floor is yours. I'll be very strict with the time for everyone here tonight because we'd like to have at least 2 rounds. So if you ask a question with 10 seconds remaining in your time, I mean, there'll be no answer. Try everyone to be as tight as you can on your time, and then we can have 2 rounds of questions for everyone. So, Mrs. Freeland, the floor is yours for 5 minutes.
Thank you. My name is Alison Freeland. I'm a psychiatrist and here in my capacity as chair of the board of directors of the Canadian Psychiatric Association and co-chair of the CPA's Medical Assistance in Dying Working Group to provide you with the CPA's perspective. Thank you for the opportunity to be here today as you consider the degree of preparedness attained for a safe and adequate application of MAID for MDS-UMC. As the national voice of Canada's psychiatrists and psychiatrists in training, the CPA's mission is to promote the highest quality of care and treatment for persons with mental illness and to advocate for the professional needs of our members by promoting excellence in education, research, and clinical practice. The CPA does not take a position on the legality or morality of MAID, nor has the CPA taken a position on whether MAID should be available where mental illness is the sole underlying medical condition. However, the CPA does believe that any legislation must both protect the rights of all vulnerable Canadians without unduly stigmatizing and discriminating against those with mental disorders solely on the basis of their disability. The CPA's primary contributions towards preparedness have focused on providing feedback on and input to national standards and the training curriculum, facilitating member awareness and education on MAID, and contributing to the literature regarding MAID. Through our working group, the CPA provided feedback on the MAID practice standard prior to its release last March. The CPA was also part of the National MAID Curriculum Steering Committee, which supported and enabled the development of a training curriculum for assessors and providers that was released in September. In addition, several CPA members have been part of the KMAP working groups that developed individual curriculum modules. CPA regularly inform members about the development of the practice standards and their contents, as well as the curriculum through our weekly members newsletter, and we continue to keep our members abreast of and facilitate relevant MAID training opportunities. At our 2022 annual conference, we held a panel discussion for 140 participants that explored ethical considerations to guide MAID decisions, assessment of capacity and voluntariness, as well as suicide versus MAID. More recently, our annual conference last month included a plenary that discussed the need for a national MAID curriculum and outlined its development. More than 300 conference delegates participated in this session. In conjunction with the conference, we also hosted a facilitated session of the MAID and Mental Disorders curriculum module for CPA members who are licensed clinicians. And it's my understanding from informal discussions with systems partners that approximately 100 psychiatrists are now registered for the MAID curriculum, and we continue to promote future educational opportunities for this training through our newsletter. Our peer-reviewed journal, the Canadian Journal of Psychiatry, has published a number of articles that seek to clarify aspects of MAID, including original research by Van Veen and colleagues that establishes 13 consensus criteria for determining irremediability in the context of MAID in the Netherlands. While psychiatrists diagnose, treat, and assess capacity in people with mental disorders on a daily basis, we will soon publish a paper on the capacity to consent in the context of MAID in the Canadian Journal of Psychiatry, and this will offer further guidance to our psychiatrists. Our MAID working group continues to be active and will meet shortly to consider further topics where members would benefit from additional guidance. CPA also has some knowledge of health systems readiness gained through members of our working group, as well as from our Council of Psychiatric Associations, which facilitates an exchange of information on issues of national importance by assembling the presidents of the various provincial psychiatric associations. As a national member organization, our role is to listen to and dialogue with our members. While some psychiatrists do not support MAID, others are interested in learning more and will choose to be involved with MAID as consultants or as assessors and possibly providers. Psychiatrists' expertise is important when it comes to MAID, but we do not practice in isolation. We work in interprofessional teams that center the voice and lived experience of the patient and their family to balance treatment, care, and hope for recovery with a capable person's right to make healthcare decisions. Thank you, and I'll be happy to answer questions.
Thank you, Madam Freeland. Mrs. Birnbaum, floor is yours for 5 minutes.
Good evening, bonsoir, chairs and honorable members of the committee. My name is Shelley Birnbaum, and I'm chair of the End of Life Working Group of the Canadian Bar Association. Thank you for the opportunity to address your committee. The CBA is a national association of 37 lawyers, Quebec notaries, law teachers, and students with a mandate to promote improvements in the law and the administration of justice. The CBA End-of-Life Working Group comprises a cross-section of members drawn from diverse areas of expertise, including constitutional and human rights law, criminal justice, health law, and child and youth law. Medical assistance in dying, or MAID, is complex and raises vital issues and diverse views, and the need to balance competing values of autonomy and protection of those who may need it. At the same time, we must realize that the suffering of individuals with mental illness is no less real than those of individuals affected by physical illness, and that persons with mental illness should have the same agency to determine their healthcare treatment as do persons with physical illness, as long as they meet the requirements to do so. We make 3 main points for this committee to consider. A total exclusion from MAID for all persons suffering from mental illness as a sole condition is likely to be constitutionally challenged as violating the equality, security, and liberty guarantees in the Canadian Charter. There are already legislated procedural safeguards in the criminal code to protect those with mental illness as a sole condition and who may be vulnerable. Number 3, additional guidance, as pointed out by Ms. Friedland, is available for health professionals and has been developed to help clinicians. A bit more detail. Constitutionality. A general exclusion of all persons suffering from mental illness is likely to be constitutionally challenged as discriminating against those with mental illness and denying them equality under the law, contrary to Section 15 of the Charter. A blanket prohibition increases suffering and likely results in breaches of the rights to security of the person and liberty, i.e. the ability to make decisions regarding bodily integrity, guaranteed to us under Section 7 of the Charter. Number 2, there's existing legislated safeguards. The criminal code already establishes a robust series of procedural safeguards that must be met before a person is considered eligible for MAID, including decisional capacity, 2 independent assessments, and informed consent. The safeguards for track 2, where death is not reasonably foreseeable, and most mental illnesses would likely fit within that category, are even more rigorous, requiring a prescribed and robust informed consent, consultation with an expert in the field, a reflection period, and determination that there's been a serious consideration of options. Healthcare practitioners are legally required to assess capacity prior to treatment. And psychiatrists regularly make capacity determinations for persons with mental illness, provide prognoses about mental illnesses, and assess risks of suicidality, which are different than MAID. Any additional safeguards must not unduly prolong the suffering of those who are otherwise eligible for MAID and should align with current best practices in mental health care. We understand that there have been many tools developed and many recommendations of the expert panel on MAID and mental illness are being implemented to ensure a state of readiness. We are aware of the model practice standard and advice to the profession documents that have been developed, as well as the comprehensive Canadian MAID curriculum with a specific module on mental illness and MAID. In addition, provinces and territories and regulatory bodies may continue to develop guidance and tools in their role in regulating health and health practitioners. MAID, where mental illness is the sole condition, has been under consideration for almost 9 years and delayed twice. We are of the view that eligibility should no longer be delayed and that the planned March 2024 implementation date should be respected. On behalf of the CBA, thank you again for the opportunity to speak today. Merci. I look forward to answering any questions you may have.
Mme Birnbaum, nos 2 témoins étaient dans les temps.
So our 2 witnesses respected the time allotted, and now I'll give the floor to my co-chair.
Thank you, and thank you to our witnesses for being here this evening. Colleagues, I'll just remind you that we have to try and be strict with our time due to the time constraint. So we'll begin with our first round of questions, 5 minutes each for each person representing the party. So we'll begin with Mr. Fast for 5 minutes.
Thank you, Madam Chair. My first questions will be to Dr. Freeland. Dr. Freeland, are you appearing at our committee today on behalf of the psychiatric profession at large or on behalf of a working group or on behalf of yourself?
Thank you for that question. Just to restate, I am here on behalf of the Canadian Psychiatric Association, which is a national member association for Canadian psychiatrists and psychiatrists in training. My role with the CPA is I am chair of the board of directors, and I also co-chair our working group focused on medical assistance in dying.
Okay, but do you speak for all psychiatrists?
I'm speaking on behalf of the CPA, which represents our psychiatrist members. As a national member organization, we have approximately 50% of psychiatrists who are members of our association. That has been a very steady rate over the last number of years. And we've also been very pleased by an increase in our members of training and approximately 19% over the last year.
Thank you.
We were also...
Thank you.
Okay.
So you represent about half of Canadian psychiatrists. I wanted to know, you chaired a committee that studied MAID for the mentally disordered. And I understand that your committee stated in March 2020 that mentally disordered patients should have the same access to MAID as available to all patients. And you've restated that today in your testimony. Now, I understand that the CPA has never formally consulted with its members in the lead up to that position statement that was issued by the committee. Is that correct?
I'm happy to explain our process for both position statements and how we've undertaken member consultations. The CPA routinely publishes position papers and statements on issues related to psychiatric practice, and we have a way of proceeding with that. Through our MAID working group, we did have a number of member consultations, which included, since 2016, the CPA has had member surveys. There's been an original time-limited task force, and we've had symposia.
Doctor, I'm not asking you to explain exactly how the consultation process works. I just want to know, if there were consultations, formal consultations with your membership, has that membership actually given you a clear consensus that they want you to move forward with this?
Are you asking particularly in reference to the publishing of the position statement, which was published and then amended when Bill C7 came through, along with our discussion paper?
Yes, let's talk about firstly let's talk firstly the policy statement, position statement that you
position
issued.
Statement. Yeah, the position statement. Our process for that would be for our Professional Standards and Practice Committee to develop something that's based on CPA policy. We actually did not take a position on the importance of not stigmatizing a group of people by virtue of their illness. So.
Yeah. Did your consultations actually result in you divining or discerning a consensus amongst your members that MAID was ready to be implemented for the mentally ill?
I think it's very well known that across all Canadian psychiatrists, and including within our membership in the CPA, there are people with different perspectives with respect to MAID for mental illness.
Okay, so there's no consensus.
As a member organization, we welcome healthy debate, which continues on.
All right.
Part of the work that we did was to develop...
That's all I need to know. So there's really no consensus within your profession at this point in time. Is that correct?
I think if you're asking about 100% consensus for some sort of intervention and issue for people with mental illness, I think it would not be unusual to consider that there's generally not consensus in many aspects of medicine. I'm sorry, I'm not sure if I'm answering your question.
About 15 seconds.
That's it?
Yes.
Oh, my goodness.
Okay.
All right. Thank you.
Thank you. And next we'll go to Mr. Maloney for 5 minutes.
Thank you, Madam Chair. I want to thank both of the witnesses for being here today. I want to pick up on something you said, Dr. Freeland. Look, I'm assuming you've read our reports from this committee in its previous incarnations?
Yes, I've had the opportunity.
So in our report in June 2022, we recommended that we must have standards of practice, clear guidelines, adequate training for practitioners, comprehensive patient assessments, meaningful oversight. The task will require efforts and collaboration of regulators, professional associations, institutional committees, and all levels of government, and these actors need to be engaged. Do you agree with that statement?
I think those are important parts of being ready for this, yes.
Thank you. Okay. So you mentioned that you were, I assume, based on what you told Mr. Fast, that you were involved in the practice standards development process on behalf of the CPA. Is that correct?
The CPA, we were asked as a CPA organization to provide some representation and contribute to the development of the standards, yes.
Okay. And if I heard you correctly, you said that 100 psychiatrists registered for the curriculum so far. Is that?
That is what I understand in terms of people that have registered for that. I can call myself one of them.
Okay, thank you for that. Now, you said that about 50% of the psychiatrists in Canada are part of your organization. How many psychiatrists are there in Canada?
Just shy of 5,000, so we are at just under 2,500 psychiatrists.
Okay, so 100 out of 5,000 psychiatrists in Canada have signed up to be part of this new curriculum for providing MAID to people with mental illness. Is that correct?
So in terms of who is currently signed up for that, that is information that I've been provided. I would say the CPA is not monitoring the exact numbers of psychiatrists.
Okay, but you would agree with me that that's a pretty low number. My math's not very good, and I'm not going to guess the percentage, but it's not very high. Don't you think it would be appropriate before this process is rolled out that a much, much, much larger number of your members have not just registered for, but have completed the curriculum?
I'm sorry you cut out at the last minute there.
I'm saying, would you agree with me that it would be important that, let me put it another way, anybody who is being consulted on MAID for somebody with mental illness has participated and taken courses as part of this curriculum?
I think one of the things to consider is that, and I think Ms. Birnbaum did a really nice job elucidating this, is that in fact psychiatrists are actually trained in a number of the important issues as an expert providing consultation to a process of assessment for MAID. So all psychiatrists undertake a minimum of 5 years of training, and what we focus on is diagnostic assessment.
Yeah, I don't want to interrupt you. I don't want to be rude,
approaches.
But I'm limited in time. I agree with you. The psychiatrists undergo some very, very serious training, extensive training. But you have been part of this process development. You have helped prepare this curriculum, and yet only a very small number of psychiatrists have actually taken part of it. Do you not think it would be preferable if a much larger number of your membership, and in fact psychiatrists across Canada, had taken the courses before they participate in the process?
Well, I think the courses they've only just been launched. The curriculum's only just been made available since the fall.
That's precisely my point. See, our mandate in this committee now, we've been tasked with determining the state of readiness, and if only 100 out of 5,000 psychiatrists have taken courses in this curriculum, or in fact, I haven't taken them, they registered for courses in the curriculum, would you agree with me that perhaps that casts some doubt on readiness?
I'm not sure about that. I would say I would still stand by the fact that in terms of what the role the psychiatrist can play as part of MAID and assessment, the point of being an expert and providing an expert opinion to those who may be trained to be assessors and providers, I believe that's what's stipulated as part of the criminal code. And I believe that would be a role that many psychiatrists could play and are already trained to be able to provide an expert consultation and opinion.
Okay, I'm running out of time. Ms. Birnbaum, you said you are part of this subcommittee has 37 members who are part of the Canadian Bar Association?
No, I said that there's 37,000 lawyers that are part of this Canadian Bar Association.
Okay, and all right.
And I represent the End of Life Working Group, which is a subcommittee of the Canadian Bar Association.
I'm going to ask this question to both of you. Is it fair to say that there is not consensus between the legal community and the medical community, in your case, the psychiatric community, about the state of readiness? Because I'm aware of a number of organizations who have made it clear that they believe they are not ready.
Sorry, we are out of time, so there could be a quick answer, yes or no. Is there consensus? No. Okay. Sorry about that. We'll move on to the next questioner, Monsieur Thériault, for 5 minutes.
Merci beaucoup.
Thank you, Chair. Ms. Freeland and Ms. Birnbaum, or rather Ms. Birnbaum earlier said that we should continue in March 2024. Are you of the same opinion, or is your association of the same opinion?
Thank you for the question. Just to clarify, are you asking me if our association is of the same opinion that we should continue, we should go forward with MAID for mental illness in March? The same opinion?
Yes, that's what I'm asking.
I think it's a complex issue. Part of what we've been trying to state is that we are working towards readiness. I think the important thing from a Canadian Psychiatric Association is that we are one part of a team of healthcare providers who are involved in medical assistance in dying for mental illness. I think many of the things that we are worrying about are actually things that have already been part of the assessments for MAID. When you think about people with any track 2 condition, many of the things that we're thinking about are also related to
Je croyais ma question simple.
I actually thought my question was a simple one. I get the impression that you can't answer yes or no, and so I understand. Now, about 50% apparently of psychiatrists have reservations about applying MAID to those with mental disorders. Now, in the brief that you submitted to the Joint Committee in May 2022, you said that regardless of evaluations of admissibility to MAID, it is absolutely essential that at least one independent psychiatrist and with expertise in mental disorders undertake a fulsome evaluation in order to make sure that there has been a specific diagnosis and an offer of treatment-based, evidence-based treatment based on standards. Now, in recommendation 10 of the expert panel's reports, they said that there had to be an independent psychiatrist as well. Do you believe that that resource now exists? That is to say, an independent psychiatrist who will also be an expert in the mental disorder in question?
So the first thing I will restate is I believe psychiatrists do have expertise in some of the areas that are pertinent to assessment in MAID, so the diagnosis and understanding refractory illness, capacity issues, and assessment of suicide. I think over the last, what we've learned more about MAID and its delivery, and we understand that no one profession can do this alone. We do feel that in most cases of MAID for mental
pas ma
illness,
question. Je sais pas ce qui
But that wasn't my question. I'm not sure if the translation isn't getting through to you, but Chair, I hope that you will take that into consideration. What I'm asking you is this. I want to know whether we have enough resources in terms of psychiatrists in order to meet recommendation number 10 of the expert panel. So in other words, do we have enough psychiatrists in order to be able to apply that recommendation that is in your own brief? Is that clear?
Thank you for the question. Yes, I think what you're asking me to do is, do we have enough psychiatry resources to do this? I think we have to step back and say, when we look at mental health and addictions, we don't have enough resources for all kinds of things that we do in the delivery of mental health care and the provision of expert opinion on a number of different issues. That being said, where an expert opinion is needed and made, and the need to gather the necessary information to determine eligibility, people may need to wait for that resource in order for it to occur, like to get the right information that's needed to make a decision. And so do we have enough psychiatrists specifically to MAID? Probably not. Do we have enough psychiatrists for the delivery of mental health care in general? Not necessarily. And the same applies for many other medical specialties where people may wait for expert opinion for other conditions that are being considered for track 2.
Si je comprends bien.
So if I've understood correctly then, there is this obligation to have an independent psychiatrist who's an expert in the mental disorder in question, and you consider that as an additional safeguard. But tonight you're saying that you don't know if there are enough resources in order to be able to apply MAID to those who are suffering from an underlying condition that is a mental disorder. Am I correct in understanding you?
No, I think I'm saying that what we understand is that there are not enough resources in many aspects of healthcare. I think what we do know is that in terms of the number of psychiatrists available to Canadians, there's probably not enough, and that we continue to have a wait list for people to access expertise.
Okay, thank you, Dr. Freeland. Tonight, I think we have Mr. Angus online, so you have 5 minutes.
Thank you, Chair. Simple question, Dr. Friedland. In 4 months, Canada's going to cross a line that we probably don't come back from. Are we ready?
Thank you very much for the question. I think that's part of what we're trying to ascertain today. I think in thinking about readiness, there's different aspects of readiness. Are we ready from a national perspective? Do we have the appropriate national standards? I think we do have those. Do we have a nationally available training curriculum for people? I think we've been able to do that. When we think about...
So.
Pardon me?
Sorry, I'm just thinking because the committee's final report in February 2023 noted, quote, there's not been sufficient time to develop the standards of practice that are key to ensuring a thoughtful, consistent approach to MAID. So I would find it in all my years of Parliament, things don't move very fast. To suddenly go from February to now to say, yeah, we're ready. I have a really hard time buying that. because we were given an arbitrary date on this, an arbitrary date by the unelected Senate, who just threw in March 2023, and then the Liberals moved it to 2024. Can you tell me with assurance that I can go back to people that I represent and say, don't you worry, if your loved one who's severely depressed decides he's going to end his life, it will be done right with all the provisions and protections. Can you tell me that I can tell people that those protections are in place now? Because 4 months, this will become law.
I don't think from a CPA perspective, I can say that all the readiness is there, because in terms of health systems readiness, the CPA wouldn't have all the information necessary to make a comment on that.
Okay.
But I can comment on clinical readiness, and
that's crucial
standards.
Because we're supposed to know that it's going to be done, quote, rationally considered during a period of stability, not during a period of crisis. This may require serial assessments. And that sounds great. That is not like anything I've ever seen in the real world. We deal in our office with people who have severe depression. We deal with families who deal with loved ones who are in a deep, dark, black hole. And we deal with the fact that we don't have any medical. Many families don't have doctors. We never have to see a psychiatrist. So in 4 months, thanks to how this has been set up, this becomes law. And someone who's in a deep, dark depression can end their life. How do I tell their family everything was done to make sure that they had all their agency? Don't you worry. If that person who's in a deep, dark depression decides to end their life, the process is there to protect them.
I think one of the things that we have to think a bit about is that just because somebody applies for an assessment for medical assistance in dying does not mean that they become eligible for that. And the standards very clearly, with the advice to the professions as part of the standards, do clearly articulate some of the things that need to be carefully considered as part of that assessment. And I do believe that there's been a lot of thought and attention to build those standards and to disseminate those and to provide advice. So from that perspective,
I don't doubt that, and I'm not questioning the deep integrity of people in the psychiatric profession, but we have a situation where I deal in real world. I don't deal with in what should be. I deal with what I see. I represent the far north, where we have horrific suicide crisis in the indigenous communities. We have ongoing mental health crisis. In fact, to the point that states of emergency have been declared. So when I asked you, are we ready? I need to know that when I go back to Treaty 9 and say, yeah, for your loved one who's severely depressed and wandering the streets, if they decide they're going to end their life, all the protections are in place to make sure this was done right. If those protections aren't right, it's our duty to tell the public we're not ready. So can you tell me that the protections are there?
I don't think I can do that. I believe that a lot of time and effort has been put into doing this. I am reflective of some of the comments that my colleague has made at the beginning of this, which is we've had quite a long time to think about this. And we have allowed other complex medical disorders to be involved in Track 2 MAID with a lot of similar issues related to mental disorder. And so we have to.
But we have a deadline of 4 months that the Liberal government has put on us. So in 4 months, this becomes law, and we break for the Christmas season very soon. So, and then we're out for January. So I need to be able to tell people, don't worry, when this becomes law, all these things will have been thought of, and I haven't heard that answer yet.
Yeah, unfortunately, we are out of time, so we'll move on to the questions from senators. Thank you.
Donc, les prochaines questions du sénateur.
Next round of questions will be from senators, starting with Ms. Meji. I have one question for each witness, and I would like you to be able to answer within a minute and a half. My first question is for Dr. Freeland. I'm going to ask you about training. There will be training for psychiatrists who will be involved in MAID. Has that training already begun or not? Yes or no?
Yes.
Okay. Et dans ces activités.
Now, in those training activities, how many psychiatrists are interested in attending. From what I understand, there aren't enough psychiatrists available to take care of patients. And there have to be patients who are dealt with, but there also have to be psychiatrists available for MAID. So are you aware of how many psychiatrists are actually interested in following that training?
No, I am not sure about that.
Okay. Okay. Merci.
Thank you. Now, Ms. Birnbaum, and I'm sorry if I've mispronounced your name. What are the criteria that were already established by the Canadian Bar Association in order to be able to safely deliver MAID for those who are suffering from a mental disorder?
So we ourselves as lawyers did not develop criteria. What we have done is look at what's existing now within legislation. And if you look at some of those safeguards, or all of those safeguards, especially for not reasonably foreseeable, it's a reasonably robust set of safeguards that would ensure that people are ready and to access MAID. They have to be deemed eligible. It seemed to us that that was a strong legal framework.
Okay.
Do you want me to articulate the criteria that are in the criminal code?
45 secondes.
In 45 seconds?
Allez regarder ça. Bon, merci beaucoup.
Yes?
Then thank you. You still have 45 seconds, Ms. Meji? No, I'm going to give my time.
For 3 minutes.
And 45 seconds. Thank you. Thank you very much to the witnesses. I think I'll use my questions first to clarify. The Canadian Psychiatric Association does not represent any psychiatrists in Quebec. Is that fair?
That would be fair.
So if you take the CPA and the AMPQ together, it's about 75% of psychiatrists in Canada.
Can I reframe that? We do have Quebec members who are part of the CMPA and also AMPQ. Sorry, my apologies.
Yeah, so they jointly. So together it's about 75%. There was a question about the large number of psychiatrists needed to, but we know from the data from the Benelux countries, there's a very, very small number of people who actually would qualify for MAID with the sole mental illness. So we really have no idea whether we need 5,000 psychiatrists, likely not, whether at the beginning we may get by with 100 or 50. So this idea that we need huge, large number amounts of psychiatrists, I don't know if that makes sense. Does it make sense to you?
Yeah, I would agree with that. And I think there are examples of where there are lots of examples, both in mental health and in medicine at large, where not everyone is part of a new thing that comes out. Not everyone is trained to do everything in all aspects of healthcare.
So the idea that we need thousands of psychiatrists is erroneous. In terms of readiness, and I think you used a nice phrase for that, have the standards of practice, medical practice, been developed?
Have the standards for medical practice been developed? We have the national standards.
Yeah,
that
so
have
they've been developed
with advice to the profession.
And
yes.
what about the curriculum? Has that been developed?
That is correct. Yes.
And it is available for psychiatrists and any other physician in the country who wishes to take it.
Correct.
And there are ongoing programs right now for more and more psychiatrists taking these programs. 5 months ago, how many psychiatrists had taken the program?
Well, there wouldn't have been any because
Zero.
we didn't have.
Okay, so we've had 100% increase in a very short time.
Correct. And I will say the one that I tried to register for, I am now on a wait list because I can't.
I can do my math. So the point here being is that we're on a trajectory of creating competencies. I know no specialty in medicine where all the competencies are done on day one, that we have a huge trajectory of creating competencies. So I think we have to be careful not to give the improper idea about medical training. Could I go to Mrs. Birnbaum? I think we're getting some confusion in the committee between assessing readiness between provincial jurisdiction and federal jurisdiction. And our job as a federal government is to assess readiness solely in terms of steps within the federal government's jurisdiction. And I'm wondering if you think that the exclusion
of people is the limit on charter rights? And what prospects do you think that a claim of lack of readiness would have as a justification for a limit on that right? How would the Supreme Court look at that justification of provincial not readiness?
In 10 seconds.
45 seconds.
Okay, so I could only indicate that there have been about 9 years to think about this, and I think there's been 3 years of delay in which there was an absolute exclusion. So I think a court would consider the fact that there's been so many years available when they look at whether or not it's a justifiable exclusion.
Le
I also
prochain
think that the
Thank you, Mr. Birnbaum. Monsieur Sénateur Dalphond.
Senator Dalphond, you have 3 minutes. Thank you very much, Chair.
Well, the question of Senator Kutcher's to you, Mrs. Birnbaum, gave you a few more minutes to complete your answer. But I had a similar questions. How can the law navigate between the potential tensions between the Charter of Rights, guaranteed rights, as you referred to the mental ill patients also have rights, but also the tensions between the fact that maybe we need also to have in place the proper standards of and training to protect the vulnerable person. So how we do the balancing of the absolute right in one sense to have access and the right to protect the vulnerable? And if the conclusion of the committee was that there's not enough readiness, will you say that it does goes to the question, the standard on question standard at Article 1 of the Charter?
Certainly lack of readiness could go to Section 1 of the Charter. However, I think in looking at the legal framework in terms of protecting a vulnerable person, there are protections built into that. There are protections that a person must be capable, first of all. So that is what psychiatrists, that is what people do all the time in healthcare. Is this person capable of making this decision? So you're going to root out those people who are incapable. And then you're going to look to see, have there been enough treatments looked at? Have the means been established, et cetera? So I think that just going through the MAID assessment process is itself a guarantee of protection of the vulnerable. So I think that that would go to the weight of Section 1, that there are significant protections there.
Shall we make a distinction between legal protections and practical protections on the field?
I'm assuming, given that healthcare practitioners have criminal liability, they have to sign off that all of the criteria have been met. And if they haven't been met, they are criminally liable. In my experience of MAID practitioners, and I've known quite a few, they take it very seriously. So in terms of practicalities, I'm hopeful they will abide by the legal parameters.
Still have 30 seconds?
Nope.
You're okay. Senatrice Osler, the floor is yours for 3 minutes.
Thank you, Mr. Chair, and thank you to the witnesses for being here today. My question is for Dr. Freeland. We've heard that there are psychiatrists who have started the training. My question is, how prepared are those psychiatrists who are either involved in assessing MAID requests or acting as consultants to MAID assessors? Can you give us an idea of how prepared they are now and how prepared they will be in 5 months?
Thank you for the question. You know, again, I think where there's requirement for consultation with an expert, I believe psychiatrists are prepared to do that because that is part of our core business, to be able to provide expert consultation around key areas of diagnosis, review of treatment plans, capacity assessments, suicidal assessments, and so on and so forth, comorbidities, et cetera. I think in terms of any practitioner who's now looking at how to become involved with being an actual assessor of eligibility. We know there are some psychiatrists already involved in doing that. We had one of them presenting at our conference last month, and there are others who are actively involved with that. It is a small number. And again, a small number who are actively part of the provision. And the growth in that in terms of psychiatrists being involved in those two specific areas I wouldn't actually anticipate that there will be a lot of psychiatrists actually being the assessors of eligibility and providers of MAID. I think the area where we will see involvement in psychiatrists is the experts in the assessment of illness and some of the important aspects of that.
Time for a second. Dr. Freeland, has it ever occurred that a new practice in psychiatry has started and some individual psychiatrists were not ready to be involved, but that practice went ahead anyways? And how did the CPA respond to such occurrences? So, for example, ketamine or psilocybin treatment.
Those are great examples, and a couple that I would have raised. RTMS would be another one, where these are active new practices, innovative aspects of psychiatric treatment and care. And there are limited people that have expertise in that, and where the CPA becomes involved because of our sort of focus on our mission on ensuring that we provide educational opportunities or access to those to help people learn more and become more engaged and familiar with some of these things. That is how we've offered those opportunities to our members in those areas.
Thank you.
Still have 20 seconds?
I'm good.
You're good. Mrs. Martin, the floor is yours for 3 minutes. I'll be tight on time.
Okay. Thank you. I'm just waiting for my mic. So I know there have been questions about the readiness and the concern of the overall readiness, and you had said you responded to some of the questions about a little bit of the lack of. So I'm curious, there's a survey from October 1st, 2023 of psychiatrists in Manitoba, where only 33% of psychiatrists responded that they are in favor of the legislation and legalizing MAID for mental illness. And in that same survey, 65% of respondents said that they do not have enough awareness or understanding of MAID. So this speaks to the lack of readiness or concern of readiness. Would you first speak to the 33% of psychiatrists that are in favor of the legislation?
That are 33% that are in favor.
Favor of the legalizing MAID for mental illness, only 33%.
I think there have been a number of different surveys that have done, and I don't think there was any survey where there would have been 100% of psychiatrists in favor of doing this. And there could be all kinds of different reasons for that. It could be how the questionnaire is set up. It could be people's not having enough training and understanding of the issue. And some people are in disagreement with this as a concept. I think one of the challenges in all of this is this is something that Canada has decided is being made available to its citizens. And in some regards, although it's important to consider what psychiatrists' contributions are, at the end of the day, whether psychiatrists want this or not, and it's a legal thing that's available to Canadians, we have to consider that perspective on all of this.
Thank you. Actually, so I wanted to then go to, just because of my limited time, that in that same survey, only 65% of respondents said that they have enough awareness or understanding of MAID for mental illness. So that of course, because psychiatrists are on the front lines and they must be ready. So what would you say to that?
Well, I would say that we are continuing to try and provide opportunities for people to increase their understanding and awareness. We're making available a connectivity to the curriculum that has only just come out. But I think, there are increasing numbers of places where psychiatrists who choose to become more familiar and more engaged with all of this can receive the training to support medical assistance in dying assessments.
And thank you. And we have heard concerns about the rural and urban issues, and that there's an urgent need up in rural communities. So the fact that there is kind of a lack of psychiatrists in some of these parts, like what would you respond to these concerns?
Yeah, I think it's a really important question, and it's something separate to this issue that the CPA would advocate on the importance of access and how do we build that. I think the use of telepsychiatry is an important step in helping to improve access to people in rural and northern areas. And looking at some of the licensure and regionalization of licensure, there's been some activity in how do we do that to support Canadians in terms of accessing psychiatry in general, not just even for the issue related to.
Thank you, Dr. Freeland.
Okay, so we're able to go into a second round. So I think, Mr. Fesh, you'll take the second round for 3 minutes.
Thank you very much. My questions are to Ms. Birnbaum. Ms. Birnbaum, you're familiar with the organization called Dying with Dignity, which is an advocacy group for those who wish to access MAID. Is that correct?
Yes, I'm familiar with it.
And are you a legal advisor to them?
No, I'm a volunteer, and I've sometimes been asked some questions, and I've spoken with them.
Have you given them legal advice in the past?
I've given them legal advice, yes.
Okay, thank you.
Ambassador, she's ambassador.
And have you served as ambassador for Dying with Dignity?
I don't know what it means to be an ambassador. I have previously worked with them directly.
All right, thank you. Have you polled or surveyed your members to determine whether they feel Canada is ready to implement MAID for the mentally ill?
We haven't polled our members in terms of whether there's a state of readiness, but our positioning is based upon resolutions adopted by the membership of the Canadian Bar Association, and that included that mental illness be available, that there be made for persons who have mental illness. There are actual resolutions that at its point of adoption were 100% in favor.
Can you actually
we have
say...
not specifically looked at readiness. No, we have not done a resolution on readiness.
Is there any consensus within the legal profession on whether the Charter of Rights compels government to make MAID available to the mentally ill?
I can only say that all of the members of the end-of-life working group who've been looking at these issues have come up with positioning that indicates that there is a strong charter vulnerability to say every single mentally ill person will not have access to even be determined for eligibility for MAID.
Now, I probably can agree, since we're both lawyers, that lawyers can often disagree amongst themselves, correct?
Absolutely, lawyers can disagree amongst themselves.
Right, and we don't know what the Supreme Court of Canada would say when it comes to requiring government to expand MAID to include the mentally ill, correct?
We don't know what the Supreme Court of Canada will say. However, the CBA has taken the position that Carter did not exclude mentally ill persons.
And it did not require mentally ill persons to be included either, did it?
It did not say thou must. That is correct.
And I'm stating the obvious. I'm stating the obvious when I say this is about life and death. Wouldn't it be more appropriate to have the federal government send this to the Supreme Court by way of reference rather than gambling on the lives of the mentally ill?
Okay, thank you. Sorry about the time.
Just a quick...
Yes or no?
Yes or no? Just a yes or no, Ms. Berman.
Okay. The CBA has not considered this in my own view, thinking about this, given our thoughts about vulnerability. I don't think in this sense
so much.
Would
Thank
feel
you
that
very
way,
much.
But we would have to check.
Okay. And next we will go to Mr. Fisher for 3 minutes.
Thank you very much, Madam Chair. I want to thank our witnesses for being here. We have such a narrow mandate that you're going to be hearing some, you already are hearing a little bit of repetition and a little bit of different phrasing of some of the questions. But the narrow mandate, of course, is just to verify the degree of preparedness attained for a safe and adequate application of MAID. Now, I've always supported MAID. Every time there was a MAID vote, I voted for it. I support the safeguards, and I certainly support the charter rights. Dr. Freeland, your organization takes no position. But can I ask you as an individual, do you think that the health system is ready for an expansion of MAID eligibility for individuals whose sole underlying medical condition is a mental disorder?
Thank you for that question. And I'm just reflecting on that as an individual. I work in Ontario, a complicated province, lots of different healthcare systems here. I would say there is still work to be done to, I think at a local level, ensure that the entire system has created a coordinated point of access. But the thing I will say that is encouraging is where I am, is now a provincial group looking at a community of practice around medical assistance in dying, particularly for mental disorder. And in Toronto, where I work, we now have a coordinated working group sponsored by the local Toronto hospitals that again is turning its mind to how to do this. It is represented with a number of different health professionals, which includes psychiatry. In fact, it's co-chaired by two psychiatrists, the Toronto working group. And I think people are working hard, knowing that there is this date in mind to get to a place of readiness, knowing that readiness is never going to be perfect, and that when we actually think about readiness in this context, compared to when MAID came out way back with Bill C-14, there's actually been a lot more work done in terms of that national approach around standards and available curriculum. And I think many different organizations engaging healthcare teams around how to best understand this. I am definitely not a MAID expansionist. I just truly believe that it's very stigmatizing. This is my personal belief, to take a group of patients and just say to them, you can't even be considered for something because you have a mental illness. I actually believe very few people would be found eligible should this go ahead with respect to mental illness. Ms. Birnbaum has really clearly outlined all those safeguards and processes that we'd have to get through to get to that point. And so those would be my personal reflections, not the CPA reflections.
Okay, there's 5 seconds remaining. All right, thank you. We'll go next to Monsieur Thériault for 2 minutes.
2 minutes.
2 minutes? Yes, 2 minutes. Many people feel that those who are in crisis or depressive or suicidal could have access to MAID, but the opposite is being said. And I want to know if opening up MAID to those with a disorder, mental disorder, could even have a preventative effect for someone who is suicidal. Let's say someone who is suicidal wants access. At least in that case, we'd know that that person needs help, and there would be some care provided, because these days there are people who are suicidal who receive no help. So do you think that actually this could have a preventative effect on those who are suicidal?
Is that directed to me?
Yes, Dr. Freeland?
Thank you. That's a great question, and I think a lot of debate about that. I think, first of all, if we were all living in a perfect healthcare system, we would want to assume that people have quick access to assessment of onset of suicidality and ensuring that they have rapid access to treatment and care in the system. And I think that's something we all strive for broadly in the healthcare system. With respect to people accessing expert assessment because of an ask around medical assistance in dying, I do think there has been some debate about the fact that when you see a psychiatrist and are able to explore your illness, understand diagnosis and treatment options, there may be many people who get to that stage and in fact would not be eligible. And one of the important parts about readiness, and I know it's something, again, I'm going to put my personal hat on, and it's something we've talked about in Ontario, is the navigation back into the healthcare system. And when you look at the standards, there is a requirement to continue to provide ongoing treatment and care for people who are not found eligible for MAID.
Thank you.
And so in that context, there is that opportunity.
And Mr. Angus for 2 minutes.
Well, thank you, Dr. Friedland. I just want to go back on the question, are we ready for March 2024? Because you had said that Canada had decided that we were going to go down this road. I would say that the Senate, which not elected, threw in a date and told us to live with it, and the Liberal government agreed. And that date was March 2023. And as it approached, they panicked, and so now it's March 2024. This is a huge Rubicon we're crossing. So what's more important, the date or getting it right? Would you suggest that we take the time to do this if it's proven that it's not going to affect a lot of people, that there's going to be all the safeguards? Do we need to meet that date, that arbitrary date that was put in between the Liberal government and the Senate, Or should we do this in light of the bigger and broader consensus that we need to achieve and make sure that people are protected?
Thank you for the question. I think it's a difficult question to answer because we are still 5 months away and the rate of activity in terms of getting ready continues to accelerate, and we continue to see people engaging around this, and I think systems of care beginning to evolve around it. And I think that's where it's challenging to say, are we going to be ready or not against a date? The date has been selected and it's already been put off once, and I do think there has been substantive work that's done. But
this isn't like opening a business. This is like people's lives and deaths right now. So, I mean, things may be moving fast, but given the huge disparities in health across this country, and this country is very large and there's huge differences, yeah, things may be moving fast enough. But can I go back and assure people, because people call me about this, this is an issue people are deeply concerned about because they have loved ones who have deep, dark mental illnesses that they cannot get treatment for because treatment doesn't exist. So,
okay, thank you. We are at what matters. 7:30, and we need to get ready for our second panel. So thank you to our witnesses this evening for taking our questions.
Thank you.
Thank you.
Après la suspension, j'aimerais faire quelques observations.
I'd just like to make a few comments for the benefit of our witnesses. Please, all comments should be addressed through the joint chairs. When speaking, please speak slowly and clearly and near to your microphone, and that will help our interpreters in understanding you. And the services provided for this meeting are the same as those in an in-person committee. You can choose the floor, English or French, at the bottom of your screen. And when you are not given the floor, please make sure you are on mute. Now I'd like to welcome our witnesses for panel 2. As an individual, Dr. Mona Gupta, psychiatrist and researcher, Centre Hospitalier de l'Université de Montréal by video conference. Dr. Douglas Grant, Registrar and Chief Executive Officer, and Dr. Claire Gamache, psychiatrist, appearing on behalf of the Association des médecins psychiatres du Québec.
Of Medical Regulatory Authorities of Canada, sorry. And finally, Dr. Gamache pour l'Association des...
And Dr. Gamache, Association des médecins psychiatres du Québec. Thank you all for joining us, and we'll now give the floor to Ms. Martin, our co-chair.
And thank you to our witnesses. We will begin with opening remarks by Dr. Gupta, followed by Dr. Grant, and then Dr. Gamache. So Dr. Gupta, you have 5 minutes. The floor is yours. Sorry, Dr. Gupta. Oh.
Thank you very much, Madam Chair. Can you hear me well now?
Yes, go ahead.
Thank you all for the invitation to meet with you today. I'm a psychiatrist and bioethics researcher at the University of Montreal. I've had the opportunity and the privilege to be closely involved in the public conversation about assisted dying for persons with mental disorders as their sole underlying medical condition, MDSUMC for the rest of my remarks, since its beginning. I served as a member of the CCA working group on MAID for MDSUMC mandated by Bill C-14. I chaired the federal expert panel for MAID and mental illness mandated by C-7. More recently, I led the work of Health Canada's task group for MAID practice standards, and I also led the working group that developed CAMAP's educational module for MAID and mental disorders. It is from this vantage point that I want to share some observations about readiness. When the Government of Canada made the decision to include persons with mental disorders as their sole underlying medical condition on equal terms with all other medically ill suffering persons whose natural deaths were not reasonably foreseeable, it committed to do 3 things: constitute an expert panel on MAID and mental illness, strike a special joint parliamentary committee to further study the matter, and revise its data collection system. As we know, the federal government has fulfilled these commitments. When the federal government made the decision to extend the exclusion for an additional year, it spoke about the need for extra time to ensure that 2 major deliverables, the CAMAP MAID curriculum and the Model MAID practice standard, were complete. As we know, these activities are complete. The standard has been in the hands of physicians and nurse regulators since April of this year, and they are adopting or adapting the standard as appropriate within their jurisdiction. The CAMAP MAID curriculum was launched in September 2023 and has been offered already numerous times to physicians and nurse practitioners. Several other initiatives have occurred since December of 2022, including a national MAID MDSUMC preparatory workshop with delegates from every province and territory, including MAID assessors, providers, and psychiatrists. There has also been a national system readiness workshop to share knowledge about administrative processes. Most provinces and territories are working with frontline clinicians, regulators, and administrative authorities to ensure that clinical processes are appropriately tailored for requesters with mental disorders. I have provided several examples of these activities in my brief. A few weeks ago, I taught the CAMAP MAID and mental disorders module to a group of about 20 psychiatrists, family physicians, and nurse practitioners in Vancouver. Beforehand, the colleague co-leading the session, an experienced family physician and MAID assessor and provider, Dr. Tanya Dawes, bounded up to me. Even though MAID MDSUMC is not allowed, she said, I've already had patients with all the same types of issues in the case studies we cover in the module. What struck me about Dr. Dawes' comment is that persons with mental disorders as their sole underlying condition who make requests for MAID will be in the careful hands of experienced clinicians who over these last 7 years have already handled the full range of complexities in their MAID practice that MDSUMC requests may present. Her comment also confirms what the expert panel concluded, that the complexities so often attributed to mental disorders are not, in fact, unique to mental disorders and are already being handled in our MAID system today. The work that has been undertaken on MAID MDS-UMC since 2017 has been thorough, the process is transparent and collaborative. The Government of Canada has fulfilled every commitment concerning readiness that it made. It has also made unprecedented contributions to healthcare professional education and regulation, which well exceed the scope of its jurisdictional responsibilities. As my colleagues, Dr. Gamache and Dr. Grant, know better than I, the other essential actors in healthcare and in the MAID system, regulators and professional associations, have been active concerning MAID since 2015. They will continue to fulfill their mandates, in the case of the regulators, guiding clinicians towards safe MAID practice in the public interest, and in the case of professional associations, ensuring their members are equipped to participate in MAID if they choose to do so. By far, more thought, care, and capacity building has been done for persons with mental disorders as their sole underlying medical condition than any others. This is a good thing, and this work will have added benefit of strengthening Canada's MAID system for all patients. If you were to ask me what I need, if tomorrow I had to assess MAID eligibility for a person with a mental disorder as their sole underlying medical condition, the answer is nothing. The work has been done. We are ready.
Thank you, Dr. Gupta. Next, we will have Dr. Grant for 5 minutes.
Speak to the committee. I'm Dr. Douglas Grant. I'm the Registrar of the College of Physicians in Nova Scotia. I'm a family doc, a lawyer, and I represented the Federation of Regulatory Authorities at the Health Canada Working Group. My approach to the question is that all readiness must be built on regulatory readiness. My respectful submission is bluntly this: the regulators are ready for this. We don't need any more time. We're not coming for more time. And we'll be ready for many reasons. The first is that most of the hard work's been done. The model practice standards developed by the Health Canada Working Group are the best synthesis of the law with the input of all necessary stakeholder voices. And I know I speak on behalf of my fellow registrars that we see this as very useful documents. The document can be adopted in whole, which Nova Scotia will do, and I can tell you another Atlantic province will be adopting it in whole as well, or used as a template to build a professional standard upon. The supporting documents provide a la carte language that can be plugged into existing college standards. At the end of the day, what will happen on March 24th is that all medical regulators will have guidance in place, professional standards in place that are built from or informed by the model practice standards developed by the Health Canada Working Group. And with exceptions for style and format, there will be substantial consistency between provinces. But the second reason why the regulators will be ready in March is that we have a solemn and legal duty to be ready. There may be some slight variations in provincial legislation, but all medical regulatory colleges have a mandate to regulate the medical profession in the public interest. That mandate means we're in service to patients. In this case, we're in service to these specific patients who are suffering, who are being denied a form of care to which they are entitled in law, and who, as a class, have been suffering and denied this care since 2015. Finally, our duty extends to physicians themselves, who look to provide this care, who are entitled to a clear articulation of regulatory direction and expectations. So I'm here to say the regulators will meet their duties. The fact that we're here implies that you've heard voices from non-regulators implying that the regulators are not ready. And I'd like to unpack those concerns. First of all, they're not supported by history. At each step of MAID's evolution, there's been a chorus of voices asking whether the regulators were ready. After the one-year implementation period was coming to an end following Carter, there were calls of unreadiness. At the time, I was the president of the Federation of Medical Regulatory Authorities of Canada and made submissions to a joint committee like this. I don't think it was in this room, indicating that the regulators were ready. And we were ready. And we were ready when the law evolved to include eligibility for patients whose natural death was not reasonably foreseeable. And then we were ready again when Audrey's amendment enabling a waiver of final consent to eligible patients at risk of a loss of capacity came into law. And I guess I'd just like to say this is par for the course. Medicine constantly evolves. MAID will evolve, and the medical regulators will respond because we have a duty to be nimble. I hope that the concerns of unreadiness are not founded in response to silence on the websites of colleges like my own. That'd be a mistake. Professional standards serve many purposes. They declare the regulatory expectations. They direct the caregivers, but they also serve a public purpose, advising the public of what they're entitled to expect. And rooms like this indicate that the situation is fluid. The regulators in the College in Nova Scotia, of which I run, will wait until the path forward is settled and political debate has stopped. The medical regulators have no desire to mislead or confuse the public. I would encourage this committee to be disciplined in its efforts to distinguish opposition to MAID from accusations of unreadiness. In my experience, the choir of voices making accusations of unreadiness has been entirely composed of voices who are opposed to MAID. With the courts having made their final decision, opposing voices cannot advance arguments to stop MAID. So I'd ask the committee to ask, are the accusations of unreadiness a genuine argument, or simply an attempt to buy time for the sake of time when no time is needed, at least not from the regulatory perspective?
Thank you. Lastly, we'll have Dr. Gamache for 5 minutes.
Bonjour. Thank you very much. My name is Dr. Claire Gamache, and I'm the president of the Association of Psychiatrists in Quebec. We'd like to thank the House of Commons for inviting us to participate in this discussion. Our association, the AMPQ, is one of 35 associations affiliated with the FMSQ, the Fédération des Médecins Spécialistes du Québec, which represents approximately 1,200 psychiatrists. The purpose of our association is to make sure there are optimal conditions for practicing our profession for our members, but it has also been very interested since the very beginning in how care is organized and on literacy amongst the public on mental disorders. The AMPQ has been involved in the discussion on MAID SUMC since October 2020. We have participated in various sittings of various committees, including the Committee of Justice and Human Rights on Bill C-7. It was also involved in the position paper, the position statement on the part of the Collège des Médecins du Québec. It has also presented a discussion document on access to MAID for people who have mental disorders. It has also been involved in the consultations of the Special Commission on End-of-Life Care in May 2021. In 2020, the board of the AMPQ approved the position according to which those individuals who have a mental disorder as the sole underlying condition should not be excluded systematically from access to MAID. At the request of the Collège des Médecins, the AMPQ published a discussion document on how MAID could be organized within the province of Quebec. And this brief was produced and crafted along with patient partners and a member representing caregivers. The AMPQ presented the work to its members during its annual meeting in 2021. In order to educate its members, the AMPQ provides professional development activities during its annual meetings, as well as an update, a day-long update on MAID for specialists in Quebec during its interdisciplinary training sessions. And it did so on the 17th of November, 2023, speaking specifically to mental disorders as the sole underlying condition. The AMPQ also testified before a parliamentary commission that was considering the issue of MAID. And during its testimony, the AMPQ recommended the government not exclude those individuals who have underlying mental disorders. Several professional associations, whether it be the Federation of Medical Experts or Family Physicians, as well as the Commission of Human Rights and the Rights of the Youth in Quebec, have also have a similar opinion to that of the AMPQ. Besides its regular activities, the AMPQ has sat on the National Steering Committee of CAMAC, and has been involved in its programs. All involvement and participation on the part of the AMPQ in the conversation about MAID's purpose is to raise awareness amongst those who are caring for people with mental disorders, individuals with mental disorders, as well as those who care for them. Our experience shows that mental disorders are not well known on the part of the public. When we're discussing MAID with mental disorder as the sole underlying medical condition, we're talking about people we have been following for decades who have tried many different kinds of therapy and treatments. There are already psychiatrists on the ground who are involved in the assessment of complex situations in the MAID process. There is co-assessing that happens as well. There are second-level assessments that happen with physicians, general practitioners. And the main objective of the MPQ is to tackle stigmatization by using our expertise and our experience for the most vulnerable. We want to avoid perpetuating these stigma. Inclusion is the best way forward.
We'll go into our first round. For this panel, I think we're only going to get through one round for each, the MP and the Senate. So we'll begin with questions from Mr. Cooper. You have 5 minutes.
Thank you very much, Madam Co-Chair. My questions are to Dr. Gupta. Dr. Gupta, you said we're ready with respect to MAID and mental illness. I would submit that's tough to accept given what we've heard in the previous hour, in which we've heard there's no consensus amongst psychiatrists. Only 2% of psychiatrists have signed up for the curriculum program, and there aren't enough resources. But you say we're ready, really. Well, I would submit the heart of the issue, however, is the question of irremediability, whether someone can get better and whether that can be accurately predicted. Now, as you will recall, at page 40 of the expert report that was issued, that you chaired, it states, quote, there is limited knowledge about the long-term prognosis for many conditions, and it is difficult, if not impossible, for clinicians to make accurate predictions about the future for an individual patient. The evolution of an individual's mental disorder cannot be predicted as it can for certain types of cancers, end of quote. That report was issued in May of 2022. Has anything changed since May of 2022 with respect to that conclusion?
So if your question is there something different about mental disorders compared to other conditions that can currently access assisted dying now? No, that hasn't changed since May of 2022. And that was exactly the point the panel was making, that yes, there are these difficulties, but these difficulties exist in Track 2 as well. And so if Track 2 can go forward and people can be afforded appropriate protections under Track 2, the same can occur for mental disorders.
It's not just a challenge, it's a criminal code prerequisite in order to qualify for MAID. And what you have said is that, and you've confirmed it tonight, that it is difficult, if not possible, to predict. And we heard testimony from experts when this committee last convened, including from Dr. Mark Senior, who said that the error rate for predicting irremediability could be anywhere from 2% to 95%. In other words, we're flying blind. So in the face of that, how can you say that we're ready?
Well, I can say that we're ready because we are doing these kinds of eligibility assessments for all kinds of complex patients, including patients that have comorbid mental disorders, where the mental disorder may play a significant role in motivating the request, that there are many medical conditions where prognostication is difficult, if not impossible, to borrow the same language of the expert panel report. And yet we reason clinically about these cases in full respect of the criminal code requirements, because as you know, no physician has been prosecuted and not a single successful college complaint has been made. So physicians and nurse practitioners are using these criteria to reason about cases when people have had, as my colleague Dr. Gamache said,
with respect, Dr. Gupta, I've given you some time to answer it, and I think you've made my point that we're not ready, not in the face of that. I would just ask, would you agree that suicidality is often a symptom of mental illness?
I would say that it is one of the criteria of a small number of specific conditions.
Yeah, at page 9 of the Health Canada Advice to the Profession, Medical Assistance in Dying, which you helped write, it states, MAID eligibility assessments must not be undertaken in circumstances of acute suicidality. What about in cases of chronic suicidality? Why is that missing from your advice to the profession?
Well, precisely because some people with mental disorders, a very small number, I think, are going to be able to make a capable, informed decision to access MAID, despite the fact that they may have also struggled with suicidal thinking over the course of their lives. And this is already the case because people make MAID requests now who may have struggled with suicidal thinking over the course of their lives.
How much time?
15 seconds.
Okay, thank you.
Okay. Ms. Kudrakis. Apologies.
Thank you, Madam Co-Chair, and thank you to our witnesses for being here with us this evening. I'm going to start my questions with Dr. Grant, and I'm just wondering if you can confirm for us, please, whether tonight you are speaking on behalf of the Federation of Medical Regulatory Association of Canada, the College of Physicians and Surgeons of Nova Scotia, or are you here as an individual?
I was invited here as the FEMRAC, Federation of Medical Regulatory Authorities of Canada's representative on the Health Canada Working Group.
Okay, great. Would you be able to please explain how the MAID practices standard task group's guidance on MAID eligibility assessments differs from what has been practiced up to this point? And my understanding is that you perhaps was a co-chair of that group?
Actually, the invitation said I was a co-chair, and I wasn't, so I don't want to. I was just a member of the group.
Well, thank you for clarifying.
Your question is, how did the model standards put forward by the working group differ from what's in practice right now? Well,
yes.
It contemplates the inclusion of people whose sole underlying medical condition is a mental disorder. It also unpacks, and I think Dr. Gupta was getting into that, some of the more difficult cases that it gives guidance on some of the more difficult cases in what are track 2 cases where one's natural death is not reasonably foreseeable.
And what was the basis for including a different approach to MAID eligibility assessments? I'm just wondering if you can go a little bit deeper.
If the question after the Carter decision, which I think most people who work in my space, we did not feel, we interpret Carter as not excluding people whose sole underlying was a medical condition could be eligible. We then were responding to a number of changes in the law and changes in direction from Parliament. So the mandate came from Health Canada to this working group to provide clarity to the professions and the providers, and not just the medical regulators, but nurse regulators, to provide a document of direction for the professions involved.
And Dr. Gupta, you very clearly stated that the system is ready. And I'm just wondering what you have heard from medical practitioners about whether they feel equipped how they feel that they are equipped to undertake assessments, provisions, consultations for MAID, where mental illness is the sole underlying condition?
So there's a full range of experience, just like there is for MAID now. There are some people who are actively involved. There are some people who are not involved. There are some people who are occasionally involved. And I would say the same thing is true for psychiatrists. Like any new and complex practice, and this is true for everything that we do in medicine, people who are less experienced aren't the people who are going to start. The people who are going to start are, like my colleague Dr. Dawes, who I mentioned in my opening remarks, who have a lot of experience, have seen a lot of patients. And they're the ones that are going to do the initial work while, as Dr. Gamache said, they train and mentor others who wish to become involved. There will always be people who don't want to be involved, and that is completely fine. And the colleges and the law allows for that. And it's interesting, we're talking about the 2%, because in fact, only 2% of Canadian physicians are MAID providers. So a small number of people wish to be involved, and those people will continue to be involved, some more than others. That's entirely normal.
And Dr. Gupta, do you think systems of MAID oversight and quality assurance are adequate across Canada? And if so, how?
So oversight, of course, as you know, is a provincial and territorial responsibility. And there are differences between provinces and territories in the mechanisms that they choose to deploy for oversight, from Quebec's Commission Soins de Vie, which is very formal, to coroner's review, to ministry oversight committees. What I can say is that 90% of MAID cases are occurring in jurisdictions with formal oversight processes. And this is what I meant in my opening remarks. One of the benefits of this extra work that has been done is that those provinces and territories that had less formal mechanisms are working on building more formal mechanisms. So this work is actually going to benefit all patients, not just patients with mental disorders.
Okay, thank you very much. And next we'll have Monsieur Thériault for 5 minutes.
Thank you, Madam Chair, and thank you to the witnesses for your clear testimony. Ms. Gamache, I asked this question earlier. I don't know if it had been understood earlier, but do you feel if opening up MAID to those with mental disorders as an underlying condition could have a preventative effect on some patients who perhaps may have suicidal thoughts but are not being taken care of? And this may actually be an opportunity for them to be able to say, I want access to this, and then they would receive that care that they haven't received in the past. I would say yes. There are already patients who show up at emergency and are requesting MAID in the context of, say, psychological distress or physical problems. And what that does is trigger a whole process whereby these people are taken care of more quickly because there are delays in the availability of MAID. And it's also an opportunity to discuss that request. That is part of the therapeutic process, and it can be very healthy for those clients who have mental disorders. You mentioned an impressive list of organizations that work in the healthcare sector and who have recommended this opening up of eligibility. How do you explain the fact that the Quebec Legislative Assembly did not want to go ahead with this? Well, we're talking about social acceptability. There is stigma everywhere, and I think, unfortunately, it also exists in legislation. So we need to think about how we deal with these clients who, in the healthcare system, we have to ask ourselves, why does it take so long for people with mental disorders? Why are they treated so differently? You know, track 2 was mentioned a few times this evening. It's complex, and mental disorders could be part of that assessment. But in terms of our concern, that is, are we ready? The Quebec government decided not to go ahead So does this create any sort of clinical obstacle? Does it create obstacles on the ground in Quebec? And how will that work then if we have a Quebec Commission on end-of-life care that's saying, well, we have to respect the most restrictive legislation if there's a choice. How will the physicians deal with this and practitioners? Well, practitioners will, yes, feel like they're stuck between two types of legislation, yes. But there are inconsistencies everywhere and have been there over the past many years. So it will be up to the Ministry of Health to deal with this, to make recommendations. And we will have to speak to our patients. And we will have to say to our patients that we'll have to wait until this is allowed because different choices have been made. So are you talking about Quebec or Canada? Where will it be permitted? Well, probably within Quebec it won't be, given the current system. So we have a Ministry of Health, and if we have a government of Quebec that cannot be provided, then we won't be able to provide that type of care in hospitals. So, Dr. Gupta, you said you're ready. Are there enough people who are trained sufficiently and are ready to proceed in March 2024?
Dr. Gupta?
I think yes, we are. And you have to make a distinction between the psychiatrist who's a consultant and the psychiatrist who is an assessor. Psychiatrists already work as consultants or advisors to doctors who are evaluating a patient. So I think those skills already exist. There are physicians making assessments, and there will be more and more of these psychiatrists as training is offered.
Thank you very much. And lastly, I will go to Mr. Angus for 5 minutes.
Thank you, and thank you, doctors, for your great expertise. It has been suggested that some of us who are raising questions about being ready is be a way to relitigate MAID. I'm not one of them. I've had some very close friends choose MAID so that they could have an end of life that they had control over with their families. They were very profound moments, and I respect that. I'm trying to see how I deal with families, with people who have deep mental illness, depression, and how I can assure them that this process is done with all the care necessary. Dr. Gamache, you said that those who would be eligible would have been involved in the medical community for decades. So if someone comes in with deep and significant suffering, deep depression, perhaps addiction, suicidal ideation, but hasn't been involved for decades, would they be still eligible?
Je crois que non.
I don't think so. If you can't access treatment, and that's what Dr. Gupta was also trying to say, you have these people then who are doubly discriminated against because they don't have access to treatments and they also won't have access to MAID. So there has to be treatment over a good period of time. Treatment has to be tried, and that discussion has to happen with the patients. And then you can decide, just like for other major physical illnesses. But if you don't have access to those services, then clearly you can't use Track 2 the way it's defined.
I guess the question I'm trying to get my head around is this issue of discrimination, the discrimination against the right to MAID or the discrimination to the right to proper medical treatment. Dr. Gupta, you said that the federal government had stepped up above and beyond in making sure everything was necessary. In the work I do as a member of parliament, we're screaming for the federal government to step up all the time on mental health, and they don't. And I represent far northern communities, isolated, rural, where we have suicide deaths from gunshots. We have people with deep mental illness who just run off into the woods and the family can't find them. So I guess I'm having a problem here of saying we're ready to have a really clinical, clear process for people to end their life, but we don't have the tools in place to be ready to keep people through these times of crisis. Like you're on the front line. What do you see?
Well, look, I think that we can all agree, probably, whatever views we might have about MAID for persons with mental disorders, I think we can all agree that mental health services in this country and addiction services in this country could stand to be improved and there could be much greater access. But I think what Dr. Gamache is pointing out is that these unfortunate souls who do not have proper access to care will not be eligible for MAID anyway.
Okay. And I appreciate this. I mean, like, I don't know anything about medicine. I mean, I dropped out of high school to play in a punk band. But my life experience is dealing with families in crisis. That's what I do as a member of parliament. We deal with this all the time. And it is a very emotional issue for people. And I have a really hard time going back to them and saying, don't worry, there will be a process for MAID, when I can't tell them that there will be a process that their loved one can get treatment. So who is eligible and who's not? If it's deep depression, I know people who have deep depression for years. I know people who are deeply suicidal for years. I'm reading the all the clinical reports on how they should be treated and how they should be assessed, and to me, it doesn't sound like real world. It sounds like an ideal situation of someone who sought this through, who comes through the door, has made an informed decision. We're dealing with people who live in storms of darkness and upheaval and then settle down and their families go with them. What are the provisions that separates that?
Is that for me or for Dr. Gamache?
Either one.
Okay, 30 seconds, very briefly, please.
Peut-être que pour répondre... Well, perhaps I'll attempt an answer. You know, there can be a lot of distress amongst people around us, but the distress is different in the psychiatrist's office. It's assessed, and what you see, you're not the person who's going to be seen by the person you know. There's a psychiatrist who sees that person, that individual, and they're the ones who discuss the options for treatment.
To all of the witnesses, and we go now to the questions from the senators.
Donc, nous allons commencer avec la sénatrice.
So we'll start with Senator Meji for 3 minutes. Thank you very much, Chair. My question requires a brief answer, and it could be from Dr. Gamache or Dr. Gupta. Last year, there was a psychiatrist who appeared before our committee speaking about eligibility, and they said that there were so many significant criteria to determine eligibility. And she was looking, or they were looking at a caseload over 30 years of career, and they only found about 3 individuals who would have been eligible, given the requirements for chronicity, long-term monitoring, etc. So I'd like to know what you think about that. Well, I agree. I would say about the same thing. After 23 years of this career, I can count maybe 2 individuals who would be. And I would say the same, says Dr. Gamache. My other question is this. It's my impression that I've heard that if all psychiatrists don't have the requisite training to be involved in MAID, we may not be ready. However, when you look at all the physicians and other health professionals, and you look at their numbers, they're not all going to be involved in MAID. So how do you see this then for psychiatrists? It's not all psychiatrists who have to be ready or who are going to be involved. Well, as I said earlier, after 7 years, only 2% of physicians in Canada can provide this. So there is only a very small number of people who are ready to work with a very small number of clients or patients. And that's the same. That's also true of other professions. Not all professionals are up to date on every aspect of that profession. They work with specific groups, targeted groups. And so there's no such thing as a practice or an area where everyone has the same level of training in the same areas. Thank you very much, Chair. Thank you, Senator Meji.
Senator Kutcher.
Thank you.
Time for 3 minutes.
Chair, just before I ask the question, could we ask Dr. Freeland to give us the two papers she referred to in her testimony for us to look at? Maybe the clerk could ask for that. Dr. Gupta, there seems to be a bit of confusion between providing treatment for a mental illness and providing MAID. If a patient wants treatment, would they actually be eligible to receive MAID?
No.
Okay, I think that's clear. Thank you. The other part here is that there seems to be a confusion between assessors and consultants, and more psychiatrists are taking on the training to become assessors. But we already have psychiatrists who are being consultants around MAID, and we expect that the number of people seeking MAID for soul mental illness will be very, very small. Do we actually have enough people in the profession that could provide the consultation that is needed? As the profession grows and develops, more will become assessors as well, because I think there's confusion between the two.
Yeah. I know personally I have never been involved or been aware of any case where a psychiatric consultant was needed to support two assessors and it was not possible to obtain a psychiatric consultation. Dr. Gamache has a view of the entire province of Quebec, can probably comment on that better than I can, and that's correct. We're already doing that work as consultants, as the safeguards say, the person with expertise, and we will continue to do that work. And I think people are becoming more and more interested as time passes in becoming assessors, and they are doing training and learning from their already experienced colleagues how to do that work as well.
Be some there have been some psychiatrists who are opposed to the whole concept of readiness. Have any of these of your colleagues, have they ever participated in any of the work to develop readiness criteria? Have they asked to participate, or is their perspective that readiness will never exist, and so therefore why participate in discussing readiness?
Well, I'm not inside their minds, so I can't tell you what they're thinking, but I'm really glad that you brought that up, because I think that some of the voices that are saying we are not ready have contributed nothing to becoming ready. And I would submit that one way of assessing whether somebody is sincere about concerns about readiness, as opposed to, as Dr. Grant said, using that as a way to express opposition, is to see what have they contributed towards becoming ready. Somebody who is sincerely concerned about readiness is going to get involved. And those voices have not been involved, even when opportunities have clearly been presented to them.
And would regulators, you have a sacred duty here as regulators, would regulators agree to allow the practice of MAID if the proper standards for the practice of MAID were not in place? I didn't hear you.
Okay. Thank you, Dr. Grant. It's all for this moment, Mr. Kutcher. Monsieur Dalphon, à vous la parole pour 3 minutes.
Mr. Dalphon, you have the floor for 3 minutes. My first question is for Dr. Gamache, but first I would like to thank our witnesses. You said that the board of your association approved your statement, that it was submitted in 2021 to the association. So based on that, I assume that you've consulted with all your members? It was presented at the General Assembly. There was no vote, but yes, it was presented to all our members. And we continue to work with them. Do you also feel that there is sufficient training among psychiatrists to avoid serious issues? Well, we're already ready for track 2, and we already deal with patients with mental disorders.
You, Dr. Grant, next to me, you said the regulators are ready and we don't need more preparation. So does that mean that because you're ready as regulators, the practitioners are ready to go forward?
Well, I would say the practitioners couldn't go forward without the regulators being ready. And the regulators will have, and we've all developed their documents, but built on the working group's work, the regulators all will have direction in place so that the practitioners, the physicians, will know what's expected of them, and more importantly, or as importantly, the public, because our standards face forward, the public will know what they're entitled to.
And you say this is the case for the 10 provinces and the 3 territories?
I can say that the model practice standards which we developed have been shared with all of the colleges. They've all welcomed it. I can say I've spoken with each of the registrars who will all use this document in one way or another to have their provincial standard in place.
So each province has made it their standards, or it's being in the process of being made the standards?
They will be using this document to either inform their standard or build their standard upon. I realize I'm speaking on behalf of everyone. I know that in Nova Scotia, we're adopting the standard as a whole.
Thank you.
Senator Delphon, you still have 30 seconds. Well, you're good? Okay. Maintenant, Sénatrice Ulcer. Floor is yours for 3 minutes.
Thank you, Mr. Chair. And my question, and thank you to the witnesses. My question is for Dr. Gupta. Dr. Gupta, this committee has heard concerns that anyone experiencing acute emotional distress can be eligible for MAID where a mental disorder is the sole underlying medical condition. Could you please take us through how clinicians have prepared and how will clinicians assess whether a person's request for MAID is a form of suicidal ideation?
Yes, thank you for that question. So clinicians on the ground are going to be drawing upon the work that has been done by the expert panel and then the task group to help clarify how to use these terms in practice. But even without that work, I am very comfortable saying I don't think there are any psychiatrists or physicians or nurse practitioners who think that acute distress is the equivalent of a grievous and irremediable medical condition. So we all understand that an incurable condition and an advanced state of irremediable decline requires, as it currently does under Track 2 for other chronic conditions, a long history of failed treatment and an inability to function in a way that gives the person an adequate quality of life. As to your question about suicidality, suicidality is already part of MAID assessment right now. And when people are in crisis, MAID assessments are either not done if that's what the person is asking for, or they are put on hold so that the crisis can be attended to. And that will be exactly the same thing when a person has a mental disorder as their sole condition.
Thank you, Dr. Gupta. Perhaps same question to Dr. Gamache.
I would say the same. You're asking me the same question? Yes. Suicidality is part of our daily work. We assess people, and even those who make a request for MAID for physical reasons may have suicidal thoughts at one point in time during that process, and then they have to be reevaluated. We have to be able to help them, protect them against these suicidal thoughts. A person who expresses suicidal thoughts, that's part of our daily work. So we'll try to understand why when they express these thoughts, understand what's happening, and it's part of the whole process. As Dr. Gupta was saying, in a moment of crisis, no one is going to be offered MAID. This is a process that is much longer and that requires at least a good 90 days before you even engage in Track 2. So in a situation of acute crisis, there is no risk of that happening. Thank you very much, Dr. Gamache.
With Senatrice Martin.
Thank you. My question is for Dr. Gupta. The president of the Canadian Society of Addiction Medicine was recently quoted with respect to MAID for those suffering from mental disorders as saying, quote, "It's not fair to exclude people from eligibility purely because their mental disorder might either partly or in full be a substance use disorder." This suggests that CSMAM believes that people suffering solely from addictions should be able to qualify for MAID. Do you agree?
Well, I think in the same logic of the expert panel, we need to focus on what are the complexities and not what diagnosis the person has. So I'm not part of that association and I can't comment on any of their internal discussions. But I would say that in order for a person with a substance use disorder to actually fulfill the criteria, they would have to have an extremely severe condition with probably very severe physical comorbidity along with it.
Any safeguards that would prevent someone whose most severe condition is an addiction from being assessed for MAID?
A person can make a request and be assessed, but they're not going to be eligible unless they meet the criteria and the safeguards are respected. And most people with addiction who do not have any of the sequela of chronic and severe substance abuse would not be eligible.
Yeah. Hear read such statements, but there's also some evidence from European countries that allow MAID for mental illnesses that twice as many women as men get MAID for mental illness, the same ratio of women to men who attempt suicide when they're suffering from mental illness. How do you explain that gender gap in this European examples, and doesn't that concern you for Canada?
I mean, it doesn't concern me in the sense that I don't think anybody knows what it means. So we can make all sorts of hypotheses about it, what it might mean, but nobody really knows. And so I think what I would caution you from doing is drawing inferences like the one that you've done in your question with respect to male and female suicide ratios. I'd caution you from drawing inferences from that because we don't know what it means.
Well, these are all questions just to say how concerned I am about this looming deadline and the fact that we have heard evidence even this evening about our lack of readiness. So, this evidence from Europe, we often talk about evidence that we can draw from to learn from for Canada, but these are very concerning examples.
Thank you, Senator Martin. Merci à tous les témoins de vous être joints à nous, d'avoir...
Thank you to all the witnesses for joining us this evening. And thank you for having been willing to answer all our questions. Oftentimes, the time is much too short, but unfortunately, we have to fit within the rules. Thank you for coming.
Be free to move in camera to discuss committee business. And for our colleague that assists with us virtually, Zoom link in camera has been sent, Mr. Angus, already. So we'll take briefly about 5 minutes. So nous suspendons.
Merci beaucoup.